back by popular demand. There was a literal outcry when we missed episode 10. I get it. They won the Emmy. I was there to celebrate with them. Great times. If you're an editor, know that I am looking for you. We are hiring. The information is down below. Fill out that Google spreadsheet. Let's get started. Be-whoop.
Teddy, 28 years old, burned in a gas tank explosion. Paramedics estimate 90% BSA.
Oh, that's a body surface area. That's incredibly dangerous. Not only is the person going to be in a tremendous amount of discomfort, pain is interesting because if you have third-degree burns, it really sears off the nerve endings, therefore you don't feel pain. Now, I've had patients who've had third-degree burns. They tell me it absolutely does hurt. I guess it really depends on the situation. But then you also have to really carefully manage electrolytes because when you have that much skin damage, you have electrolyte abnormalities. You can dehydrate quite quickly because skin actually acts in a way where it prevents water loss. Very dangerous situation. Very, very dangerous.
Vitals are good. Pulse ox 97.
Teddy, are you in a lot of pain right now?
Not as much as I should be.
Yeah, see, so those nerve endings are most likely charred. And you know, when people say first, second, third degree burns, what they're really talking about is how far the burn goes deep. So a first degree burn is just a superficial epidermis layer of the skin. Second degree is considered a partial thickness burn where it's epidermis and partially of the dermis. Third degree is a full thickness burn, epidermis, dermis, potentially muscle, fat, bone, tendon underneath, all of that.
Mainly third degree.
Yep.
Singed nasal hairs, soot in the oropharynx.
Do you have family on the way? Amy, my wife,
What happened?
was transferring gas from a 200-gallon field tank to my tractor. Kaboom.
Let's set up for intubation.
Also really dangerous because he's going to develop contractures, which can lead to something known as compartment syndrome, where certain areas might not be getting perfused with blood, therefore develop hypoxia, necrosis. So you have to monitor this situation quite thoroughly. That's why we have dedicated burn centers in a lot of hospitals or in a lot of regions, because it's a very specialized team that needs to take care of these patients.
Don't touch me. I'm fine.
Jesus Christ.
Oh, well, so get her into a room. She's a patient now.
Holy shit.
Grab an ice pack.
I got the cart.
Does he know what happened?
What happened?
Just got punched. Just took a pull.
She's such a champ. Just got punched.
Just an unhappy patient.
A patient hit you?
Yeah.
Happens all the time. Got my cheek broken.
I lost it too.
We've all been assaulted.
Yeah, assault on healthcare workers, as Noah said on our podcast, it's so underreported, undercounted, undertried in terms of our legal criminal system. A change needs to happen because it's just not right that first responders, nurses, physicians, even EMTs face such abuse on the front lines without truly being protected or compensated fairly.
Did you hit your head?
Hi. Probably, but no LSC, just a bloody nose.
Okay, pressure.
Okay.
With a bloody nose to that degree, it's very possible that it's broken. And in a situation like that, you have to make sure that there is no septal hematoma. If there is a hematoma, which is just a collection of blood in the area where the septum is, you need to drain that quite quickly. That's an urgent intervention because if you don't, it can actually lead to necrosis from putting pressure on the area where there's not great circulation to begin with. And as a result, you can develop a saddle nose deformity. Here's an image of that. And you obviously don't want that to happen in order to have healthy breathing.
Any trouble seeing? Any double vision?
No.
I'll grab you new scrubs.
What about headache?
Yeah, a little.
You need to find her a room.
I do not need a room.
Dave, move north one to the hall.
Follow my finger.
So follow a finger, he's making sure that all of the orbital muscles are intact that attach to the eye. These are neurologic, neuromuscular tests, but also checking for fractures because if you do have a fracture of, let's say, the floor of the orbit, sometimes that can impact nerve and muscular function.
The arm is intact. I'll get a wheelchair. Pupils are equal reactive. No septal hematoma.
Boom, my guy's making all the right choices. I'm acting like I'm the ER doctor when I'm totally not.
Tell me when it's sore.
So a lot of times for a nose fracture, You don't need to do surgery. Again, if there's a septal hematoma, you might need to drain it, but a lot of times you can do a closed reduction.
Tender denasal, CT head, maxillofacial.
I'll give them a heads up.
If you do an x-ray of the area, you get a two-dimensional view, and sometimes it's really hard to actually rule out if there's a fracture happening. That's why you need a CT scan of the area. Normally, I don't like ordering CT scans of the head, but in a situation like this, when she took a fall, maybe got knocked out, that is a mechanism of injury that is compatible with getting a CT scan.
You guys staying ahead with his fluids?
Per the Parkland, 4 per kilo times 90% burned.
Wow.
27 liters over 24 hours. He's had 2 so far.
That's the equation that they use to decide how many liters of fluids they're gonna give back to this patient. You have to be very careful when ordering fluids where you don't wanna overdo it, you don't wanna underdo it. And remember, if you have burns, you are losing more fluids, much in the same way, obviously to a smaller extent. If you have a fever, you lose fluids more rapidly. If you have diarrhea, you lose fluids more rapidly.
I'm Teddy's wife. How is he?
He's stable for now.
I'm okay, honey.
Okay.
Teddy, you've got severe burns covering most of your body. You've also burned the inside of your throat. Just to be safe, I need to put in a breathing tube and you won't be able to speak.
We need to do this now before his throat swells and it becomes difficult for him to breathe. So if there's anything you two want to say to each other, this is the time to do it.
They're doing this very smart because they're doing it prophylactically. They don't want the throat to swell, and then it becomes very difficult to get an airway. Then you would have to make an incision in the throat. Whereas right now, the swelling hasn't started yet. You can get a good airway in, will protect the airway, would allow him to keep getting oxygenation, and allow him to recover while under sedation.
Code stroke, emergency department. Code stroke, emergency department.
Ketamine gone in.
Uh-oh. Code stroke means that someone's either having an ischemic or a hemorrhagic stroke. Those are the two types of strokes. Ischemic being that there's a blockage in the blood vessels that supply oxygenation and blood flow to the brain. If you have a hemorrhagic stroke, that means a blood vessel has ruptured and then there's bleeding into the brain. Both are actually the same problem in the sense that they're not receiving oxygen. One is a problem of a blockage not receiving oxygen and blood flow. The other one is because there's bleeding, therefore you're not getting oxygen and blood flow. And the most important thing when you're finding a patient who has a stroke is time. You want to act as quickly as possible.
Jane Doe, looks like she's in her 20s. Obvious aphasia, right-sided hemiparesis, and facial droop.
All right, so what they're describing here are important factors to think about when there's a stroke. We have an acronym. The stroke organizations use FAST as an acronym. I like BFAST. And each letter has a different meaning for it. B for balance, I for eyesight, face for facial asymmetries, A for arm weakness, S for speech abnormalities or difficulties, and T, the most important, time. The reason time is so important is that you want to minimize the amount of time that the brain suffers hypoxia. Because what happens is if you have a very long time where the brain is hypoxic or a region of the brain is hypoxic, not receiving oxygen, damage can happen, so much so that even if you open that area after the fact, the damage can be permanent or even become worse, where an initial infarct in the brain starts actually spreading. It's called the penumbra.
Open your mouth. Gag reflex present?
It's important to know if a gag reflex is present as it gives you some idea of whether or not the patient can protect their own airway and whether or not they need to be intubated.
Straight to radiology. CT brain without contrast, perfusion scan, CT angio, head and neck. Hey, Crow, anybody?
Yeah. Who gets a stroke in their 20s?
I would say one of the most common causes of a stroke in someone in their 20s, outside of having an aneurysm that ruptured, which actually happened to the actress on Game of Thrones, is if you have a hole between your two atria that has not closed, and as a result, a blood clot that potentially can, let's say, happen in the legs from sitting for too long, actually makes its way up the venous system, and then because there is that hole, ends its way up into the left side of the heart, and then gets shot out to the circulation, potentially the brain, causing a stroke.
Ma'am, can you close your eyes for me? Robbie, it's Samira. The endo CT came back. No bleed, but there's a carotid artery dissection left neck with a thrombocyte throat clot to the left middle cerebral artery.
Wow. That was way more than what I expected.
With no intracranial hemorrhage, she might be a TNK candidate.
But couldn't TNK cause a brain bleed and kill her?
TNK is still the best clot busting possibility.
Shouldn't we do endovascular therapy? I mean, that's the safest option.
So there's two ways that you can go about dealing with a clot. You could either have the endovascular team pull the clot out, go in and pull it out. And another way is to use a clot buster to actually break up the clot. I don't know the exact distinctions that need to be made of who's high risk, who would benefit from each operation. I'm sure there's a whole criteria that ER physicians use. But I'm surprised that they're not deciding that based on some criteria as opposed to just arguing it amongst themselves.
What do you call a Tyrannosaurus under stress?
What?
Nervous Rex.
Dr. King, meet Dr. Mehta, one of our esteemed stroke neurologists. NIH stroke scale of 27, no last known well time.
The problem with giving clot buster is if you don't know the recent stroke time, it could actually be more problematic, increasing the risk of a bleed. So I think that's when endovascular is the correct move, but let's see what happens.
Dr. Mehta, should we take her to EVT?
Not yet. Take first spin in the MRI. Check for irreversible damage first. There's a diffusion flare mismatch. She's still in the window for thrombolytics.
And she still gets AVT. 2-for-1 special.
What type of person is best suited to work with an MRI machine?
A trained technician.
Someone with a magnetic personality.
Here's your driver's license and insurance card, Mr. Puglisi. Have a seat, and the triage nurse will call you back soon.
Thank you. Hello, my son, he needs help, his eye.
Let me ask you about your eye. Do you see the line you just cut?
What? No, please, it's an emergency.
You think everybody's waiting for manicure?
We caught a line drive to the eye.
We're so sorry, ma'am. We thought this was the line for pediatrics. I'm 16.
Show her. Show her.
Oh, that's a lot of swelling. Orbital fracture. Oof. A lot of times when a baseball hits the orbit there, you get what's known as a blowout fracture in this thin area on the inside of the orbital area. That is quite painful, lots of bruising. You could also have a ridge fracture a little higher up, but this bone is a lot stronger. Obviously, the floor can also be damaged, the orbital floor, but there you'll start seeing neurologic signs, muscular issues where the eye can't move into a certain direction. Obviously, you want a CT scan urgently here.
Tell me how many fingers I'm holding up.
I can't tell. Oh my God, oh my God.
Again, orbital floor could create issues with the nerve. Also, hematomas, swelling could put pressure on the nerve, making it difficult to see as well.
Okay, tell me when the light turns on.
Now?
Light perception only.
Do you want a portable slit lamp?
Definitely. Givardi, what do you think of the anterior chamber?
Hythema.
Exactly. Grade 4.
What you can develop here is called acute orbital compartment syndrome, which is what I was saying earlier. When you have a fracture, you develop a hematoma, and that hematoma starts putting pressure, essentially cutting off circulation because of the amount of pressure that's happening there, and obviously nerve dysfunction as well. It's basically a form of mass effect. I was talking about it earlier in terms of the burn patient, but it totally applies here as well.
You see how the eye is pushing out? There seems to be a collection of blood behind the eyeball. The eye pressure's too high. We have to act quickly.
Okay, we'll check the pressure.
We're going to right now. Add some drops of the fluorescein strip.
This strip is something I use quite often in my practice to see if there's a corneal abrasion. And you apply it to either the outer or inner portion of the eye, and the stain soaks into the area. And then using a Woods lamp, a UV light, basically like a purple night light type thing, you're able to see if there's damage to the cornea where there is increased uptake.
Hold still.
Okay.
Left eye pressure 58.
Is that high?
Yes, it is. 1% lighter with epi, push 1 over his head, open a lateral canthotomy trace, excuse me.
Oh, wow, they're gonna do that right now?
We need to do a little minor surgery to relieve the pressure behind your eye, so we're gonna cut a small opening on the side of your eye, not in your eye. Got it? Yeah. You wanna watch?
It's gonna be bloody. Probably best to not watch.
No, I'll sit down.
Numbing medicine here, okay? Okay. Pinprick and some burning.
Oh, I hate the form. There's not great control there over the needle.
So after you cut his eye, see again?
This will give us our best shot at preserving his vision, yes.
I can't believe he does this procedure. I'm obviously not an ER doc, but I've never seen this done.
The length of the crushed area is going to be your guide for the length of your cut.
God, again, I just really don't like the fact that she's so distant. Like, I would use these 2 fingers and then put the index finger to guide the scissors to have better control.
Good. Good.
Do the forceps.
I really feel like in most hospitals, they would call an ophthalmologist to deal with this.
Well, that's a lot of blood. Okay, let's get a repeat pressure.
It's getting a lot brighter.
Pressure of 18? Perfect. TT can take him as soon as we dress the wound.
Let's page ophthalmology and tell him to prep for surgery.
I love that now ophthalmology is getting paged.
She's waking up.
How are you feeling?
Okay. Are you trying to say okay?
Yeah.
The thrombolytics are working. Can you lift your right leg for me? That's okay. Try moving it from side to side.
Yeah, moving against gravity is still hard. So it goes from moving against gravity to moving against resistance. Also, neurologic deficits take some time to recover. They're not just instantaneous.
Dana's CT results are back.
No intracranial hemorrhage, no skull fracture, non-displaced nasal fracture, but the rest of the facial bones look intact.
Any hemorrhaging into the sinuses?
Nada.
Great. We could really use her back on the floor.
What? You can't bring her back on the floor. She has post-concussive syndrome where she's literally having a terrible headache. One of the parts of returning to work or any kind of activity after a concussion requires a gradual return, not, oh, you fell and you have no serious damage or injury, return back.
Let me take a look. Whoa, she's a real beauty, all right. But your CT came back clean. Nothing Mother Nature can't heal on her own.
Too bad. Looking for a free nose job.
Probably get hazard pay.
2 for 1.
Oh, you know, you're cleared to go back to work if you want. Or home.
Please send her home. Please don't make her work the last 2 hours of the shift. This is so ridiculous.
I'm sorry to bother you. I just want to make sure that Teddy's not in any pain.
Oh, he's heavily sedated. He can't feel a thing.
Right. It's just that when I look at him, I just feel so helpless.
Look, his CT scans came back negative for internal injuries. He's on IV therapy to replace any lost fluids. I assure you, we are doing everything we can to give him the best treatment possible.
Thank you.
Yeah. Teddy's ring.
The reason they have to do that is likely he will swell and then the ring will get stuck there and cause an issue.
I had to cut it off because of the swelling. Hopefully you can find a good jeweler to fix it. I don't know how it works.
I need some help in here.
What's going on?
Respiratory distress. Sats are dropping 87%.
Lung injury from the fire?
It's not just the low sats. Events showing high peak pressure, low tidal volume.
That means he's not able to take a full deep breath. I just don't know why the med student is running in to make this diagnosis, right? He's a fourth year med. I always have this issue. He's a fourth year med student. Why is he making decisions?
Wait, what's that? What's going on?
Ventilator is having trouble pumping air into Teddy's lungs.
Sometimes that can happen as a result of pulmonary fibrosis. It could happen. Oh, also, he has this massive burn. As a result, it could cause that compartment syndrome-esque situation where it's actually acting like a binder around his rib cage and not allowing his lungs to fully inflate.
Burnt skin loses elasticity. Now his chest wall's too tight.
What can you do?
We're gonna have to cut the burnt skin. Release pressure on the chest wall.
I love that he's getting ready for the procedure, bro. You're a med student. Chill.
A little more pressure. Yeah. You make a decisive incision and get through the S-curve into sub-Q.
Okay, now the horizontal incision, Dr. Langdon. And connecting the two incisions.
Oh God, it's so aggressive. He's gonna need grafts, obviously, in order for the skin to heal.
We're taking him up to our burn unit. He'll be in great hands. They've had lots of experience with cases like Teddy's.
What now?
We will continue with IV fluids and pain meds. We'll support his breathing with the ventilator, and we'll keep his wounds clean, look for any signs of infection.
Then later, the plastic surgeons can do skin grafts.
He's gonna be okay.
Teddy's condition is very critical. so no promises, but our team is going to do everything they can to give him the best chance possible.
That's great guidance because you're being as genuine as possible, but still very hopeful, optimistic, and reasonable given the current medical status of the patient.
I can't begin to thank you enough, Dr. Whitaker.
Student doctor.
Except he rushes in, makes a diagnosis, and performs the procedures.
Dr. Santos, a moment, please. So, how's your first day going?
So far, so good.
I don't know.
Okay, if there's anything that could affect my ER, I need to know about it, and you have a responsibility to tell me.
Uh-oh. Did he get caught taking benzos?
There's been some inconsistencies with meds intended for your patients.
What?
Frank, have you been helping yourself to benzos from the ER?
Yeah, I've been stealing blood, too.
I asked you a question.
Wait, are you serious? What are you doing? Really? Santos. Whatever the hell she told you is bullshit.
I didn't mention Santos.
You didn't have to. I told you, she is trouble.
Have you ever taken a patient's medication?
This is insane. This is completely insane.
I need you to open your locker.
Yeah, right.
Open your locker.
You're gonna open your
locker, or I will have security smash it open.
Man, if he just keeps his benzos in his locker, he's not even a good thief. Is this ethical? He's gonna get in trouble for doing this.
Is the imprint code on these pills gonna match Louis' Librium? Go home, Frank.
No, it's not like you think. You remember whenever I helped my parents move, I was too cheap to pay for movers. I hurt my back. I told you that. You teased me about it. Remember? Well, our own Dr. Hagen prescribed me some pain meds and muscle relaxers. I was just weaning myself off. It was just for maintenance. I'm done. Robbie, come on. You know me, Robbie. You know me, man. I'm sorry. I f***ed up. I was trying to...
I don't want to steal pills.
No, it's not like you don't understand.
I don't understand.
It's not like you think. I'm not high. I'm not high. You've seen what I do, Robbie. Could a drug addict do what I do?
Yeah, high functioning ones. We see that all the time with alcoholism, benzodiazepines.
I just let him. You're done.
But what happens, like, from a staffing perspective? I don't know this because I've never ran an ER. Like, he sends a doctor home mid-shift. Now they're down a doctor. So do they replace him? Do they call the night shift person in? Doesn't he have to call the higher ups? I don't know what's supposed to happen from a procedural standpoint. Being an ER doctor or family med doctor? What's harder? Click here to find out. And as always, stay happy and healthy.